Hello everyone, and welcome to Message 1, Chapter 24, Caring for Clients with Valvular Disorders of the Heart. So our learning objectives for Chapter 24, you can find this list in your book. We need to know 5 disorders that commonly affect heart valves. You should also be able to discuss the assessment findings common among clients with valvular disorders, as well as name 3 diagnostic tests to confirm valvular disorders. You should be able to identify consequences of valvular disorders, and you need to know at least 5 categories of drugs used to treat valvular disorders. You should also be able to give 2 examples of treatments other than drug therapy to correct a valvular disorder. And last, discuss nurse management of valvular disorders. There are some words that you need to know. Become familiar with these words. You're going to see them throughout the cardiac discussions and lectures. So first, just a quick review of your heart structures. You've already had this in your introductory chapter for the cardiac unit. We have 4 cardiac valves: the aortic, mitral, tricuspid, and pulmonic. Structures can be affected by malformations at birth, inflammatory and infectious disorders, age-related degeneration, structural damage after an MI, which is a myocardial infarction, also known as a heart attack, or injury from an intracardiac procedure, such as a cardiac cath or a CABG. Your left heart side consists of the aortic and mitral valves, while your right side consists of your pulmonic and tricuspid valves. So our valvular disease consists of stenosis. Stenosis is a narrowing of the openings. When we talk about insufficiency, we're talking about backflow, or the backflow of blood up into the chamber. And that is regurgitation, so that is your backflow. Then we also have valvular disease that is congenital or is acquired. So, as a result of the aging process, our heart valves can become stiff, and that does not allow the valve to close properly, and that can result in a murmur. Patients with valve disease are at risk for decreased cardiac output. When you have a decreased cardiac output, that means that there is less blood flow to vital organs, such as the kidneys, and this could lead to kidney injury. Also, you have less blood flow that is circulating in the heart. That can lead to an MI. So, whenever we talk about risk factors, we look at hypertension, rheumatic fever, infective endocarditis, Marfan syndrome, and like I just said, older adults, so the aging process. So when I gave the example of a kidney injury as a result of your valvular disease, you should monitor the urine output. That's what you need to do. So whenever you have valvular disease, you've got a decreased cardiac output, which you learned about in the previous chapters. Your decreased cardiac output can affect those vital organs. So when you have that decreased cardiac output, make sure that you are monitoring that patient's urinary output. Make sure that you're monitoring their blood pressure closely. Now, one way that we confirm or we look at those structural changes is through a transthoracic or transesophageal echocardiography. And that's the best technique to identify those structural changes as a result of the aging process, as a result of the hypertension, as a result of the rheumatic fever, the infective encarditis, and the Marfan syndrome. So you want to do those echoes, those echocardiographies, to look at those structural changes that occur within the heart. And that will kind of help you to determine the extent of the valvular damage. So first, we're going to start with disorders of the aortic valve. So let's begin with aortic stenosis. And stenosis is narrowing and calcification, and this occurs in the aortic valve. The valves can become stiff and rigid. It can be hard for them to open and close. That's where you get that stenosis from. Now, the causes can be calcification or rheumatic fever, as we've already discussed. What does our patient present with? Well, they may have possible heart failure, they may have some angina, or they can even have syncope as a result of the aortic stenosis. So how do we confirm aortic stenosis? Well, first you can do an EKG, and that will lead you to maybe some possible ST changes. But your confirmation really comes from your echocardiogram, which is designed to look at the structure of those heart valves. And that's how you see that aortic stenosis. We can also follow that up with a cardiac cath, and that just assesses the valve area as well as the coronary flow to the valves. When you assess the patient, you may hear a murmur on the right side at the second intercostal space. You may hear a murmur at that point. But how do we intervene? So we're going to intervene by surgical management most of the time, especially if it's causing the patient to have some consistent problems such as heart failure or syncope. We may want to replace that valve. And when you replace that valve, the patient then will have to be placed on some type of blood thinner anticoagulant for the rest of their life because of that valve replacement. So when they have a valve replacement, we have to follow up with what's called an INR, which is a blood serum test that tells us how we need to adjust that anticoagulant medication, which most of the time is called Coumadin or warfarin. We're going to make those adjustments based on the INR result. Lots of times for a prosthetic mechanical valve, we like that range to be 2.5 to 3.5 for an INR on a patient with a mechanical valve, such as an aortic valve. So this is just a layout of the aortic stenosis rather than a visual. As you see, it's the narrowing of the valve. Lots of times you may see it in your older adults. It can be a result of degenerative changes as a result of aging. In our young adults, it's a congenital defect that you may see with your Marfan patients, or it can be a cause from an infection like the rheumatic carditis or the infective endocarditis. So a review of our assessment findings. Some of the patients are going to be asymptomatic. Then again, you may have some that have dyspnea and fatigue during activity. They may become dizzy, have some fainting, which is, your syncopal episode. They could have angina, which is a form of chest pain. Their carotid pulses may feel weak when you go to check those pulses. Like I say, you may hear a murmur or some type of split sound. You may hear a prominent S4 whenever you're listening to the heart sounds. The patient can develop pulmonary edema. They can also have PND. Now, PND is paroxysmal nocturnal dyspnea, and this is acute shortness of breath that appears suddenly at night. This usually wakes the patient up, and that usually can occur after just a couple of hours of sleep. But that is what PND is. You may have orthopnea. They may develop some congestion, and they may have some narrowed pulse pressure. Here on this slide, there is a link to a video that will explain to you pulse pressure. And like I said, it is an indicator of heart health, and you may have a narrow pulse pressure with your aortic stenosis. Remember again that with the aortic stenosis, you're going to have that decreased cardiac output. You learned about cardiac output in your previous chapter. And when you have that decreased cardiac output, that is when the valve is narrowed and you have insufficient nourishment to the myocardium and other organs. So the myocardium is not getting the blood flow that it needs to produce adequate cardiac output. So your kidneys are not receiving adequate cardiac output. So you can have a kidney injury or a kidney damage as a result of that. So you want to make sure that you monitor that patient's blood pressure as well as their urine output, because you're looking for any type of kidney injury or kidney failure as a result of the lack of blood flow to those organs. So let's review those diagnostic tests. Chest x-ray to see if the patient's in congestive heart failure. An echocardiogram to see the structures of those valves. An EKG or an ECG, those terms we use interchangeably. We're going to look for any ST elevation on those EKG readings. And then a cardiac catheterization to see if the patient has any decreased blood flow to those structural areas. So how are we going to manage that? Like I said, we can do some surgeries. We can also do some medical management. So your medical management is going to be maintaining that cardiac output. So for this, we're going to give some medication. We're going to give digitalis, also known as digoxin or lanoxin. We're going to give some medication to improve that cardiac output. That improves the squeeze function, makes that heart squeeze a little bit harder to improve that cardiac output. We may have to give some diuretics because of the structural inability for that blood to flow. You may have backup of blood into that area, and that may cause the heart to enlarge, and that will lead to some heart failure. So you may have to give some diuretics to get rid of that excessive fluid. Monitor the patient's sodium intake, or ask the patient to monitor their sodium intake, which is difficult to do. We live in the South. We all like our salt. It's hard to get a patient to change that salt habit that we all grew up with. In some cases, such as your infective endocarditis or your rheumatic fever, you're going to have to give the patient some antibiotics. We can also treat them with nitrates, beta blockers. So when we talk about the beta blockers that we're going to give, the patient may have some dizziness because of the change in their blood pressure may be a little bit lower, so they may have a little bit of dizziness, or they may have some side effects that they don't like. as a result of taking some of these beta blockers. But you just have the client report those findings to the primary care doctor. You should encourage the patient not to abruptly stop their medication. They should never stop their beta blockers without notifying their physician first, because they can have withdrawals from those beta blockers, and that can lead to rebound sympathetic overactivity as a result of that. Now, before you administer a beta blocker, you as the nurse, you need to make sure that you check the patient's apical pulse. If their apical pulse is less than 60, you should hold the medication and inform the primary care provider. Now, a primary care provider may say, I want you to give that beta blocker if the patient has a heart rate less than 60 but greater than 50. You would give it within that range. If they write the order for that, you would be fine. But always make sure that you check that patient's heart rate, especially apical rate, before giving that beta blocker. Whenever we are caring for a patient that has aortic stenosis, we need to monitor that patient for any signs and symptoms of any impending problems or complications they may have. You need to make sure that you explain procedures and techniques to the client as far as their diagnostic testing. If they're going to have an echocardiogram, they need to know that that's painless. If they're going to have a cardiac catheter, they need to know that they're going to have to be NPO and they're going to receive some dye from that. So you just need to make sure that you explain procedures to the client. Make sure that you administer those prescribed medications. You're only going to hold a medication if it's going to cause your patient harm, such as if you're going to give that beta blocker, make sure that the heart rate is 60 or better. If it's less than 60, you need to hold that because you don't want to cause any harm to your patient. But you always need to let the provider know if you're going to withhold any medication. Institute measures for adequate cardiac output and tissue oxygenation. So you need to make sure that the patient can tolerate their activities, make sure that you are encouraging them to move, and make sure that they're getting adequate oxygen. If they need some O2 nasal cannulae to help them oxygenate those tissues and get oxygen to those vital organs, then you need to put some oxygen on them. Dietary modifications. Like I said, controlling that sodium, which no one likes to do, is one of those modifications we need to encourage our patients to do. As far as a nursing diagnosis, decreased cardiac output. That's going to be a low blood pressure, a low heart rate. That can be a low urine output. We can have fluid volume excess. You're going to weigh that patient the same time every day. If you see an increase of 1 or 2 pounds overnight, that's fluid volume excess. You're going to look at that patient's PO intake as well as their IV intake. You're going to compare that to their urinary output. You're going to see if there is a positive intake or a negative intake. And then, of course, non-compliance. Is the client taking those beta blockers, taking that digitalis, taking that Coumadin every day like they should? Are they exercising like they should? Are they making those dietary modifications like they should? So you want to monitor the patient for non-compliance as part of our nursing diagnosis. So now we're going to move from aortic stenosis to aortic regurgitation, also known as aortic insufficiency. So this is when the aortic valve does not close tightly and blood leaks backwards. It is valvular incompetence is also a term that we use with that. It's caused by damage to the valves or papillary muscles. It can also be caused by rheumatic carditis, endocarditis, syphilis, age-related stretching, so as we age, it's part of the aging process, or proximal aorta, stretching of the proximal aorta. Systemic inflammatory conditions can also cause that. Back in the 90s, there was a weight loss drug known as fen-phen and Redux that a lot of women took. So they developed aortic regurgitation as a result of that from that weight loss drug that was very common back then. So you have a fluid overload in the left ventricle. Now, know your heart structure. Where is that aortic valve located? So that you have that overload of fluid in that left ventricle because the blood cannot push through. So you have high pressure and you have interference with a atrial emptying. So with that blood pressure being high, sometimes we call it pulmonary hypertension, and that can be signs of that can be tachycardia. They can have a low systolic pressure and decreased stroke volume. That can be some of your symptoms associated with that pulmonary hypertension as a result of that aortic regurgitation. The patient may have a productive cough with pink, frothy sputum, and that indicates progression of the disorder. So the valve disorder is getting worse. And as that worsens, the patient may develop that heart failure, which we'll see. And when they develop that heart failure, we're going to need to treat that with some Lasix or some beta blockers to help treat that heart failure as a result of that insufficiency. So let's review your assessment findings. So is the patient tachycardic? Means their heart rate is greater than 100. What does their skin look like? Is it flushed? Are they diaphoretic? What does their systolic pressure look like? Is it elevated? How about the diastolic? Is it low or normal? Do you hear a heart murmur? Do you have complaints of exertional dyspnea, which means that the patient's up and walking or going about their normal activity, and all of a sudden they get really short of breath with any type of exertion? So exertional dyspnea. Pulmonary congestion or that pulmonary edema, do you see that? So one of the first things that you may notice in your assessment findings with this patient are palpitations when the patient lies flat or they're on their left side. They may have that feeling of palpitations whenever they're turned on their left side or they lying flat. They may feel that. Your later stages, as the disease progresses, is when you're going to start having that more dyspnea and even some chest pain associated with that. So remember, tachycardia, those palpitations when lying flat or on their left side, that can be one of your first signs of your aortic regurgitation. And then your later signs are going to be that dyspnea and your chest pain. So as far as diagnostics, it's the same as stenosis. You're going to do that echocardiogram to confirm that the valve has been damaged or that the valve is not working properly. That's going to be your confirmation. You're also going to do that cardiac cath. You're going to do that chest x-ray, EKG. Essentially, it's the same with regurgitation as it is stenosis. Your management medically is going to be the same. The same medications, digoxin, which is digitalis. Your cardiac glycosides, that is the category for that. Your beta blockers, which is a category. Your diuretics, which is your category, your Lasix. Your antibiotics, remember, depending on the cause of the disorder. And then your management is the same. Replace the valve. That's what you're going to do. So diagnostics and medical management and surgical management are the same for regurgitation and stenosis. Once again, I just want to remind you about if your patient does have a heart valve, they need to probably be on some type of anticoagulant or some type of blood thinner. They're going to be on Plavix. They're going to be on Coumadin. If they're on Coumadin, you have to maintain that INR between 2.5 and 3.5. The physician will adjust the dose of the Coumadin or warfarin depending on the therapeutic range that they want the medication to be within. Your nursing management is essentially the same for regurgitation as it is stenosis. Prepare the client for a diagnostic procedure. Monitor responses of the medication. Monitor the heart rate, rhythm, shortness of breath, chest pain, loss of level of consciousness. Give those prescribed medications. Do your blood pressure teaching, diet modifications. All that is essentially the same for regurgitation as it is stenosis. So now we're going to move into mitral valve disorders. So mitral stenosis is when the valve, mitral valve, becomes narrow. And with that narrow, when you have a restriction of that blood flow. Now, causes can be rheumatic carditis and recurrent endocarditis. That inflammation causes the valve to become thick and rigid. That can result in incomplete emptying. You can also have arterial emboli. Pulmonary hypertension can also cause that, as well as right-sided heart failure. So heart murmurs, palpitations, orthopnea, and pulmonary edema are symptoms that are caused by the stricture or narrowing of that mitral valve. Mitral stenosis and mitral insufficiency both create regurgitation of blood back through the mitral valve, and that can lead to your heart murmur. They can have a cough, pink, frothy sputum, and crackles in the bases of the lungs, and that's signs of your pulmonary congestion or your pulmonary edema, is whenever you hear those crackles. JVD is your jugular vein distension. And know that lots of times these patients have to sleep in almost an upright position. They can't lay flat to sleep. They can't get comfortable when they lay flat. So they sit up most of the time whenever they sleep. So that's just part of some of your assessment findings. So if you know that your patient has mitral stenosis, you may want to assess those sounds in the left lateral position because you may hear a murmur. That's the best place you'll hear that murmur. When we talk about tachyarrhythmia, we're talking about a rhythm usually that's greater than 100. But the most common dysrhythmia we see with these patients is a rhythm called atrial fibrillation. And we will learn more about atrial fibrillation in chapter 26. But just know that atrial fib is a dysrhythmia that is associated with mitral stenosis. On this PowerPoint, on this particular slide, there are a couple of links to some videos and some further reading that you should investigate to learn more about your mitral stenosis. So as far as managing the mitral stenosis, as you see, the diagnostics are the same. You're going to do an EKG to look for ST changes. You're going to do an echocardiogram to look at that structural changes. You may do a cardiac cath to look at the blood flow to that surrounding area. Your medical management is the same. antibiotic therapy. You may be looking at preventing or relieving those symptoms of heart failure by giving that patient diuretics and beta blockers, digitalis. We may be looking at giving them daily aspirin or other anticoagulants such as your Coumadin or your Plavix. You're going to be monitoring that INR level, especially if they have a valve replacement. We can look at cardioversion. That's if the atrial fib gets out of hand and the patient can't tolerate it. We're going to do a cardioversion then. You may do a percutaneous balloon valvoplasty to kind of open up that valve area. Your nursing management is essentially the same. You're going to monitor those physical changes, blood pressure, pulse. You're going to do that diagnostic prep work for your patient. Explain all those procedures, explain all those blood draws, all those diagnostic tests that you're going to be doing. Explain that to your patient and prepare them. Discharge planning is going to be part of your nursing management as well. You're going to teach them about drug therapy. You're going to teach them about maintaining compliance and taking the medication like they should. And you're going to encourage them to report any complication with their drug therapy or any signs and symptoms that it may have that the disease or the is getting worse. So as you review your PowerPoints, be sure to click on the link here to look at a cardioversion in real time of a client with atrial fibrillation. When we talked about your anticoagulant therapy, once again, your therapeutic levels are going to be 1.5 to 2.5 for your PT. Your INR, however, should be 2.5 to 3.5 on those clients who have a prostatic valve replacement. So your mitral regurgitation is when blood flows backwards into the left atrium during ventricular systole and leaks. You just have a small amount leaking into that left ventricle during atrial diastole. The causes of mitral regurgitation, once again, we see rheumatic carditis, but it can also be caused by mitral valve prolapse. It can be caused by damage to the papillary muscles, an impairment as a result of an MI, which is a myocardial infarction, also known as a heart attack. So with mitral regurgitation, our findings, when you do your assessment, the patient's going to complain about chronic fatigue, some shortness of breath, especially on exertion. Once again, we're going to see those palpitations, that fluttery feeling in the chest. Your S1 sound may be diminished. You're going to hear an S3. So when you hear an S3, an S1 and S2, that's considered your normal heart sounds. And whenever you do your assessments in the hospital, you're going to document your cardiac sounds as S1 and S2. If you have a patient that you know has congestive heart failure, you can listen and hear it's a third sound. You're going to hear a third sound right after the S2. And it can be as a gallop, as an extra sound you may hear. And whenever you hear that S3, that's an early sign of impending heart failure. Your assessment findings can also be hypertension, tachycardia, and you may have that blowing murmur. Now, mitral stenosis and mitral insufficiency, also known as your mitral regurgitation, both create regurgitation of blood back through the mitral valve. And that can lead to that heart murmur, which is your third sound, which, like I said, is your early sign of heart failure. So your diagnostics here are going to be the same. You're going to be doing an echo to look at the structure, chest x-ray looking for heart failure, EKG, ECG looking for ST elevation. Your medical management, essentially the same. We're going to have beta blockers. You're going to have your DIG. You're going to have diuretics. We may give this patient, however, some ACE inhibitors. We may give this patient some antidysrhythmics. We may give them some calcium channel blockers. We're going to give them these type of medications to treat their mitral regurgitation. Once again, you may do a valve replacement, may do aortic balloon pump temporarily to surgically repair that mitral regurgitation. And here for my visual learners is a diagram showing the difference between left and right-sided heart failure. We'll have more detail on left and right-sided heart failure when we get to that chapter at a later date. But know that your mitral regurgitation can cause your heart failure. So you're going to monitor that blood pressure, heart rate, and rhythm. You're going to assess those heart sounds, listening for that third heart sound. You're going to listen to those lung sounds. You want to see if you hear any crackles in those lung sounds. And then you're going to report any signs of heart failure to the physician, because that's going to let him know that that mitral regurgitation is getting worse and that they may have to eventually take this patient to surgery to correct that heart valve. So many of you have heard of mitral valve prolapse. Some of you may even have it. But it's when the valves enlarge, they become a little floppy. And they will actually bulge back into that left atrium. So when that happens, the blood flows a little bit sloppy, you might as well say. It doesn't get through there like it should. Now you're going to see mitral valve prolapse more commonly in young women than men. Now the causes can be idiopathic, which means there is no cause, which means it just happens. It's just one of those things that just happens and you can't explain it. It can also be caused by rheumatic carditis, inherited connective tissue disorders, and coronary artery disease. So your patients may be totally asymptomatic, no complaints. They may not ever know they have mitral valve prolapse, ever, until for some reason they may have an echocardiogram done, and then that may show up then. Some patients may have chest pain, palpitations, that fluttery feeling, fatigue, anxiety, rapid irregular heart rates, shortness of breath, may have some lightheadedness, difficulty concentrating. You may have a click during that ventricular systole that you're going to hear whenever you do your cardiac assessment. So the echocardiogram shows the abnormal movement of mitral valve leaflets during systole, and it can assist in the diagnostics of mitral valve prolapse. And you're going to use that along with clinical symptoms that the client presents with to make your diagnosis. Now, you're only going to do some medical management or surgical management if the severity of the mitral valve prolapse is significant enough. And you may have to do some antibiotic therapy depending on the cause. You may have to treat them with digoxin, beta blockers, calcium channel blockers, low-dose aspirin, and anti-anxiety medications, especially if that heart rate gets up so high and you feel that impending doom that you may want to calm the patient down. Once again, depending on the severity, the patient may have to have a valve replacement. And as far as your nursing management goes, to relieve the chest pain, have the patient lie flat and elevate their legs. Restrict alcohol. If you have mitral valve prolapse, avoid caffeinated beverages. That's just going to increase your heart rate. So make sure you avoid those caffeine in someone with known mitral valve prolapse. And promote adequate fluids. Lots of times dehydration may cause the patient's symptom become worse, so encourage them to adequately intake PO. You want to really push that PO fluid. Encourage the patient to exercise. Have them monitor their blood pressure. So as far as your nursing management, it just depends on the patient's presenting signs and symptoms and the severity of their mitral valve as far as their management goes. So here are some common drugs used to treat your valvular heart disorders: antibiotics, anticoagulants, antiplatelets, your cardioglycosides. Your beta blockers is another one, as well as your ACE inhibitors, are also some of your medications that we use to treat your valvular disorders. Here are some medications, your antiarrhythmics and your ACE inhibitors. So as far as the drugs go, be familiar with your categories. Once you kind of learn your categories, learning the names of the medication kind of becomes second nature to you. So just make a list of some of the more common drug names that you're going to come across during your reading of your clients with valvular disorders. And this concludes my lecture for chapter 24. And remember, guys, if you have any questions, don't hesitate to drop me an email or a text if you have any questions about chapter 24. And know that no beauty shines brighter than that of a good heart, which I know you all have. Have a wonderful day.